want to welcome everyone to the 4th annual PTLI Disruptive Innovation in Physical Therapist Education Summit, challenging our assumptions about teaching and learning, creating cultures of excellence in education and practice. We are so glad that you have decided to join us for this event. We are very excited about this year's topic, and we have assembled an incredible lineup of speakers for you. Before we get started, I would like to acknowledge and thank the DI Summit Planning Committee that put this event together. We have Laurel Abrazazi, Peter Altenberger, Mary Blackington, Greg Hartley, Steve Tepper, and myself, Karen Abraham. We really have an incredible team, and I really do think we put something really special together for this weekend. Before we get into the program, I'd like to first of all pull up my slides.
Beth.
There we go. And also, I'm going to turn over the program to Barb Shapey. Barb is the immediate past president of the Physical Therapy Learning Institute, who is going to share some background about PTLI, our mission, and some of our initiatives. Take it away, Barb.
Sounds great. Well, welcome everyone. It's really very exciting to see you all. So on behalf of our incoming PTLI president, Dr. Jen Green-Wilson, who is in flight to France as I'm speaking, and all of my other board colleagues, we want to welcome you all back. For those who have participated in the summit before, we're very excited to see you join us again for this year's summit. I also want to welcome those new to the summit and expect that you will find that our talented group of presenters are going to encourage thoughtful reflection, lively discussions amongst all of our participants, and recommendations so that we can enhance student learning of within our respective environments. We're expecting over 125 participants this year in this summit. As you may know, it is an invitation-only summit, unlike most of our others. And the DI committee defines the topic for us, identifies all the presenters, and leads our discussions in these next 2 days. And they do all the preparation and all the grunt work truly to get this summit to really become a reality. But then what they also do is they ask each of our board members of PTLI to nominate guests who we expect really will contribute to the conversation. So as our guest, we have decided and we recognize that you all are individuals who can motivate others to lead change in our academics and our clinical communities. We look forward to exploring a variety of topics related to learning sciences together in these next couple of days, and hope that you're going to return to your own spheres of influence to implement at least one new idea that enhances DPT education. Next slide, Beth. Currently, there we go. Currently, PTLI offers 3 flagship initiatives that affirms our mission and moves us closer to our vision as an organization, which is to be recognized for our leadership in driving change, challenging the status quo, and collaborating to ignite innovation that will influence physical therapy education, as well as research and practice. PTLI was founded by 2 visionary leaders and trailblazers in physical therapy, Dr. Geneva Johnson and Dr. Linda Woodruff, who, as dear friends, originally envisioned PTLI to be a think tank that would be able to influence, disrupt, and yet encourage collaborative, positive changes within our education communities. We are really very proud to continue to move forward that honors their legacy as we begin to create new opportunities for us moving forward in the future. We currently host 3 flagship events that serves as our organization's 3 major pillars. We'll be celebrating the 11th annual Geneva R. Johnson Forum that fosters a space for innovation and incubation of new ideas. And it serves as the keynote for the ACAP and the Academy of Education Leadership Conference that's held each October. Our second pillar honors Dr. Linda Woodruff, and it's intended to really affirm and support
How's it
her
going?
passion to improve awareness and encourage action to mitigate ongoing professional challenges related to JEDI and anti-racism.
Right away.
This will be
I mean,
the LDW lecture as that will be offered this June in 2024. And then this summit is our third pillar of the organization, and it aims to bring current hot topics in physical therapy education to the table for discussion, with the goal to spearhead plans for both individual and collective actions that will celebrate our current PTLR board's priorities. This brings us to who we are and what we really stand for at this moment. So next slide, Karen. I want to introduce the 25 board members that make all of these events happen. As you see their faces, I would suspect that many will recognize that you will see people that have been known in the profession to be very action-oriented, to be influencers, collaborators, and of course, drivers to ignite change in our professions. Some of us have been known to be not only disruptive, but deviants in a variety of ways. And that was both Jeannie and Linda's legacy that they passed on to us. We welcome each of you to join us in our journey to continue to influence and shape our future. And I'm sure that we're going to learn from each other in these next 2 days. So I encourage everyone to participate as much as you can. And I also want to thank you for giving of your precious time to join us for this year's summit. Thanks again. And Karen, I'm going to send it back to you to introduce our speakers.
Thank you, Barb. The theme of this year's summit is teaching and learning in physical therapist education. I think most of us in academic roles would agree that most of us receive very little formal education in the science of teaching and learning. Our academic and clinical teaching practices are often based on assumptions about teaching and learning, and new faculty are frequently ill-prepared for their roles in teaching, mentoring, coaching, assessment, and others. How often do we ask ourselves, what evidence do we have to support our choice of teaching and learning activities, assessment strategies, or instructional delivery? Or how are we coaching and mentoring academic and clinical faculty regarding the knowledge, skills, and behaviors related to teaching, learning, and assessment? We believe that teaching is far more than transmitting knowledge or clinical skills, and that continuous learning across the learner continuum is imperative given rapidly complex and changing clinical settings. Therefore, over the next 2 days, we hope to look in the mirror and challenge our assumptions about teaching and learning by turning to research from the learning sciences. We hope to explore teaching and learning strategies to promote competence in physical therapist practice, core competencies for academic and clinical teaching, faculty development, assessment strategies, and more. To kick us off, we are thrilled to have a dynamic duo presenting our plenary session. We are excited to have Dr. Maria Mylopoulos and Dr. Nikki Woods from the Institute of Health Policy, Management, and Evaluation at the University of Toronto with us today to present their talk entitled Designing for Failure, an Instructional Approach for Future Success. Dr. Maria Mylopoulos holds her PhD in Human Development and Education. She is currently Senior Scientist and Associate Director of the Wilson Center for Research and Education, Program Director and Associate Professor in the Health Professions Education Research PhD concentration at the Institute of Health Policy, Management, and Evaluation, Associate Professor in the Department of Pediatrics and Curriculum Scientist in MD Education at the Temerty Faculty of Medicine, University of Toronto. Over the last 15 years, Dr. Mylopoulos has successfully led a program of research aimed at understanding the development and performance of adaptive expertise in medicine, with a particular focus on identifying the ways in which expert clinicians move beyond application of their past knowledge when appropriate to address the needs of patients, as well as the limits and opportunities of their own contexts. In her work, Maria uses a range of methodologies and theoretical frameworks from cognitive psychology, clinical reasoning, and the learning sciences to evolve understanding of the knowledge, capabilities, and learning experiences that underpin adaptive expertise. The ultimate goal of her research is to translate this understanding to educational design that promotes the development of expert clinicians who are able to handle the complexities and challenges of the healthcare workplace. Dr. Nicole Woods is the Richard and Elizabeth Curry Chair of Research in Health Professions Education. She is also director of the Institute for Education Research, TIER, at University Health Network and senior scientist at the Wilson Center, University of Toronto. Dr. Woods leads an internationally recognized research program that uses methods and principles from cognitive psychology to advance medical education theory and practice. Her research has significant implications for education across the developmental continuum and various health disciplines. A fellow of the Karolinska Institute Prize for Medical Education Research since 2019, Dr. Woods is currently a professor in the Department of Family and Community Medicine at the University of Toronto. In 2021, Dr. Woods was recognized as one of Canada's top 100 most powerful women by WXN. Welcome, Dr. Mylopoulos and Dr. Woods. Thank you so much for being here today. I will now turn the presentation over to you.
Thank you, Karen. I'm just getting that off my screen. Thank you so much. Thank you for a lovely introduction. It's always a pleasure to speak to such an obviously engaged and passionate group of educators. And this event is truly inspirational. Listening to how you describe it, its history, and what you've been doing and what you're doing is exactly the type of thing that Nikki and I just absolutely love. So thank you for inviting us to be part of this conversation and discussion. And we hope to, I think there's ample time at the end of our presentation to learn from each other. So we're very much looking forward to that. So Nikki and I have worked together for a reasonably long time. There's no need to attach numbers to things. And I think that we really have been quite inspired over the last 2 decades or so around how to think about the learning sciences, how to think about concepts from the learning sciences and education, and think about how they work and would be applied in health professions education, and do research in that space so that we can also then inform back to the theories that are underpinning learning sciences more broadly. So we think of ourselves as, no, we don't think of ourselves, we are people who do applied theory building. And it's really inspirational to be able to share that with educators, because you are a great part of that work. You are the reason why we do it, and also a part of how we construct knowledge and understand things. So today, we're talking about designing for failure, an instructional approach for future success. And the idea of learning from failure is a concept that has a very long history in the learning sciences. And we thought it's particularly salient right now and timely in terms of some of the conversations that have been going on more broadly in the world. And I think that it has a lot of potential if it's understood well to really shape and transform the future of health professions. So I think as we work on this concept and think about this concept, it's appropriate to start with John Dewey back in 1933, who said the origin of thinking is some perplexity, confusion, or doubt. And Dewey is maybe the original constructivist, and I'm sure you've all heard his name. And it really focuses on this idea and concept that we can't just go through the world complacent. Everything can't sort of just automatically make sense, and nothing really triggers any sense of wonder or even confusion or some feeling that we don't understand something. And it's that lack of understanding, possibly a cognitive conflict, possibly a tension with something we've known from before, that really leads to deep learning and understanding. And Dewey articulated that a very long time ago. More recently in the learning sciences, Dan Schwartz and John Bransford talked about this idea of a time for telling, and that if we tell answers too early in a learning experience of any kind, whether it's in a classroom, in a workplace, or anywhere else, it can lead to superficial knowledge and impede the ability to learn in the future. And what they're really pointing to is that what you want to do is create that confusion, that perplexity, that doubt, that struggle, and in order to create the perfect time for telling, for the educator to come in and help resolve that struggle that the learner has been experiencing. So they termed this a time for telling, and I think it's really quite powerful, because we often think about the time to tell in the wrong way, and we'll talk a little bit more about that. So productive failure is really a concept that builds on all of this. And it's defined as engaging students in solving problems requiring concepts they have yet to learn, followed by consolidation and instruction on the targeted concept. And I'm going to pause here for just a minute and really emphasize the followed by consolidation and instruction on the targeted concept. Otherwise, it's not productive. So failure in and of itself is not a powerful learning experience. It has to be carefully designed and thought about and followed up with a way to have the student feel and hopefully succeed on an assessment as part of that feeling, that they have learned the target concept that you were trying to help them work through. So failure must be followed by feedback and consolidation in order to be productive. And I'm belaboring this point because what Nikki and I have found through presenting some of this work in many spaces is that people always say, but failure doesn't feel good. Students don't like it. Why would they want to fail? How can we just avoid this whole feeling and experience? And what we're really trying to get at is that when you do productive failure well, students do not come out of this learning experience experiencing it as a failure. The productive failure experience should actually be one of success ultimately. So productive failure can be contrasted quite meaningfully with direct instruction, and direct instruction is often how we teach. So we give students some content, and that content can be something we've asked them to read in advance, or it could be something that they do with us in the classroom. And then we ask them to use that content and demonstrate to us that they understand it through that use. Productive failure flips this all around. It says, okay, let's have students first engage in a challenge, a problem that they should not be able to solve. So you have very deliberately calibrated it at a level where they should not be able to solve this problem effectively. And as they struggle, as they generate questions through that struggle, and that can be guided and scaffolded in meaningful ways, that creates that time for telling, where then the educator can come in and consolidate and provide feedback and answer those questions that students have now generated. And that sort of engagement that is really grounded in that confusion that John Dewey talked about and that struggle is really what creates that deep learning and deep understanding. So productive failure and this model of or design of education has been quite prominent in the learning literature in the K-12 education space, certainly, and also in higher education. Less so in health professions education for many reasons that we can maybe unpack later. But I mean, I think that there are probably some cultural elements to it as well. And so we set out back in, I guess it was papers in 2019, but a little bit before that, to think about how to think about the concept of productive failure in a health professions education space. Because people said, oh, well, the knowledge is different, the learners are different. How would we actually make this work in where we are? So we embarked on this project with one of our wonderful students, Naomi Steenhoff, who's a pharmacist. And we designed a productive failure experiment to see how this concept would play out in a pharmacy classroom. So we had students do one instructional condition, which was the productive failure condition, where they were asked to try and work through, and I'll get to what exactly they're asked to work through, asked to try and work through a concept and generate an answer that we knew that they wouldn't be able to solve. And then the other group got direct instruction. So they were sort of given, they were talked through the concept, and then ultimately, at the end of both of these instructional conditions, the key thing is that they both received the formula. This was creatinine clearance. So when they come at the end of these two instructional phases, they both receive the correct answer. And there's a practice phase where they practice using the formula. And then they do an acquisition assessment, which is how well did you acquire this knowledge? Application, how well can you apply it to some standard knowledge tests, so transfer. And then a preparation for future learning assessment, which we care a lot about as we think, and we'll unpack that later for you as well. And that's really the idea that in the stem of the question, there's some sort of information that has implications for how you're now going to solve this problem. And you need to understand the implications of that new learning in order to solve the problem effectively. So the problem was how to calculate creatinine clearance. And Naomi, who's a pharmacist herself, talked about how this was a really great one to use because what you see is that in pharmacy practice, experts often are able to move beyond the specifics of the formula and think about when it doesn't apply based on patient situation, patient characteristics, whereas novices typically don't. So it seems that, this is a real space where what you're seeing is that typically novices tend to sort of take this formula, try and apply it unreflectively, even when it's really not working. So she thought, okay, this is where I want to do this work. And what we found is that participants in the productive failure condition significantly outperformed those in the direct instruction group, specifically on the preparation for future learning assessment and without compromising acquisition and application knowledge. And this is really quite key, because what it means is that they still acquire and retain and all those things that we want traditionally from education. They're able to take the formula and use it effectively. But when introduced with novel content and novel information that should shape the way that they apply this formula to a problem they've never seen before, they're able to understand the implications of that knowledge much better than the group that receives direct instruction. And that's really quite important. And another feature of this study, and I know Nikki always hates when I don't put up graphs, but another feature of this study is that the participants in the direct instruction group actually did better in that initial practice phase. So they did, it was a strong instructional condition, but where they faltered was specifically on their capacity to understand and integrate new knowledge into their problem solving in a situation they'd never seen before. So based on that, and based on the learning sciences literature, and based on what we see in health professions, it looks like teaching complex topics earlier in the curriculum using designs like productive failure can support knowledge acquisition, and application and preparation for future learning. And the reason that, again, we emphasize this is because we are often told, no, they're not ready yet. We can wait. We can do this later. We can get to it later. Later, we can focus on the more complex things and we'll just start them easy. But when you carefully design a curricula, you can really start from the very beginning by engaging students in that meaningful struggle in order to generate that active learning and deep conceptual understanding. And I will turn it over to Nikki.
You would if Zoom would let me. Hang on. It's not letting me kick you out. Can you stop sharing and then it will let me? There we go. That's it. Okay, so hopefully that worked. Can you all see my screen?
Yeah.
Okay. So one of the things we wanted to do today is to share with you our work on productive failure. And we could just stop there and tell you, trust us, this works. We've done it a million times. We could also cite other researchers. Kapoor has done a lot of work on productive failure. You'll just have to take us for our word that it is a fairly robust phenomenon. And we're confident that it's high quality education. So we could just stop there if we wanted to, but you'd be very unsatisfied, because when you go to actually implement any of the work that you see in the learning sciences, you have to take it a step further if you're really going to make it work for you in practice. It's one thing to say, okay, yes, this is a concept that has been shown to be effective, but if you're going to actually implement it in your own schools, in your own classrooms, with your own students, the next step is understanding why it works. Because if you understand why it works, then you can play with the concept, play with the construct, and actually use it in your own practical environment. Without an understanding of why, you're kind of stuck if you can't exactly teach creatinine clearance the exact way we did in the study. So what I'm going to walk you through is some of the underlying learning mechanisms. And I'm going to be upfront. If you had somebody else coming in, they might tell you another version of the mechanisms. You're going to get our specific version. So what we're trying to explain to you is this particular finding. We have demonstrated, and Kapoor's work has demonstrated, that productive failure supports knowledge acquisition, it supports knowledge application, and it prepares students for future learning. And so what we want to understand is, what's the mechanism by which it actually does this? And so there's probably a multitude of ways that you can support acquisition, that you can support application. And so when you start doing this type of work and trying to unpack mechanism, it's really easy to just try to jump to the task, the orienting task that the students are doing, and try to guess and say, okay, well, what is that task doing for the student? What are they benefiting from it? And when you look at something like productive failure, you might want to really analyze the activities that the student's engaging in the moment. But because you're listening to the Nikki and Maria show, we're going to not focus on the activities. We're going to focus on the underlying learning and memory mechanisms that are really driving the value of that activity, because, spoiler alert, we're cognitive scientists and cognitive psychologists. So for us, these are the principles that are going to matter the most. It's going to be these type of learning and memory mechanisms. And so if we're trying to understand this, we have a wealth of other literature that we can draw from to really understand this kind of memory trajectory. And so the piece that we think is most useful here is understanding really early work from CogPsych on levels of processing. And so there are literally decades of work that look at the way students process content and how the impact and the depth of that processing can lead to better memory and better retention. And one of the most kind of just seminal findings in Cog Psych is work that was done by Craig and Tulving, showing that if you were just asking students to do basic memory work, just kind of learning to memorize a list of nonsense syllables or even a list of a memory list of words, what you see is that you can ask them, you can provide an orienting task that really just orients them to the structure of the word. So maybe they just look at whether or not how the word is spelled correctly. Maybe they just look at how to use the word, find a rhyming word, something like that. Versus you can have them process the information a lot more deeply. You can get them to find meaning in the word. That would be semantic processing. And what you see over numerous experiments is that the deeper you process information, the more likely you are to remember it, the better you are at learning it. And so you can start to think, okay, what does that mean for education? It basically means that any task that encourages deeper processing is going to encourage better learning and long-term learning that you also see in some of the studies. And so this graph, I do hate when Maria doesn't include graphs, so I include graphs as often as possible. And so this graph is actually an aggregate of a whole bunch of experiments. And what you see across all of them is that if I give participants, again, an orienting task, so either I give them a list of words and I say, just check the spelling of the word, which is just surface level processing, versus use the word in a sentence and reflect on its meaning. That's the other orienting task. Then I can also add another manipulation where I tell one group, you are going to have to learn this, so try to remember it. Versus the other group, I don't even tell them what they're going to do. I just give them the orienting task. And what we can look at and what we see over all of these studies is even the students who didn't intend to learn the words will learn it better if the orienting task requires deep processing. So what that tells us is virtually any task that we create as instructors, whether or not the students like it, whether they want to be there, whether they are enjoying it, as long as they are engaging in the material in a deep way, they will in fact have a better chance of learning that material down the line. So active learning generally does work. It's grounded in cognitive psychology. Here's the thing though, we were talking about productive struggle. And so what I would argue from this body of work is that really any guided or unguided discovery approach would actually promote deeper processing, for sure. You don't have to do productive struggle to get deeper processing. There's lots of different ways to produce deeper processing. And most of those ways would probably support acquisition and application, because those types of knowledge are best linked to what I was just describing in the Craig and Tulving studies. But what we saw in the study that we were showing you is that productive struggle gives you this extra thing. It gives you this extra piece of preparing learners for future learning and preparing them to learn novel content. And that's the piece that we think is key. So let's unpack that a little bit more. What does it take to not only get acquisition application, but also prepare students for new learning? And so we have a series of studies that look at this. I'm going to just show you one of them. We look at two groups of students. These students are learning to diagnose neurology cases. So these are undergraduate medical students. One group is an integrated instruction condition. So they're learning the basic science of these general categories of neurological disease. The other students are in the clinical group. So they're learning the same categories without the basic science. So no biochemistry, no anatomy, just these are the clinical features and the clinical associates. We have both students learn these two sets of materials, really boring didactic lectures, nothing active, but they're learning different types of content. They then complete an initial assessment, which tests their ability to diagnose those 4 different broad categories. We then challenge them to learn something new. So this is our common learning part, where we give them a brand new set of diagnostic categories that are related to the earlier ones, but it's new content for them. And then we assess them on their preparation to learn that new content. And what we see in this study is that the students, when we look at their initial performance, there's no difference between the groups. But when we look at that preparation for future learning assessment, it's the students who had that integrated understanding, the students who had the biochemistry, the anatomy, the physiology, deeply connected to the signs and symptoms, they outperform the students who only understood the clinical science on that PFLA assessment. So what that tells us is that integration of basic science can actually better prepare students for future learning. Why does that matter here? It's giving us a hint. What the integration of basic science does is provide a very specific type of knowledge. That type of knowledge is what we call basic science or conceptual knowledge. So if we're, again, I come from a cognitive psychology background, this is not specific to medicine or dentistry or PT or anything. This is a concept that would apply across the board to pretty much any form of knowledge. All form of knowledge can be considered organized in what we call a semantic network. There are two, and I have an example here of just a basic one that would apply to any everyday category. The key thing to keep in mind of all of these concepts is that in a semantic network, there's always two components. So it's this broad network of boxes and lines, you can consider them here. It's all of these abstract concepts and specific experiences in memory. There are nodes, which are the boxes, and there are lines, which are the connectors. The connectors hold the whole network together, and the connectors are the basic science. So it's those connections that are key to holding the network together and allowing the network to grow. Every time you learn something new, you add a new connector and a new box. That's being prepared for future learning. And so what we've seen from many of these studies, again, we're just showing you one of them, but what we've seen from many, many different studies is that it's this addition of connections that is really helping students to continue to learn new information after their initial instruction. So what we know from this work is that productive failure has one very specific purpose and one very specific advantage that would go beyond other active learning measures or methods. And what it does that other methods don't do is it allows you to build conceptual knowledge. So productive failure gives you those connections that you need that hold the semantic network together. Other forms of guided discovery, other forms of unguided discovery, you run the risk of students spending lots of time playing with nodes and building more and more nodes that are unconnected and aren't really linked to one another. It's that opportunity to deeply think about mechanism that you're really benefiting when you use a productive failure approach. Having said that, there's still a lot of different ways to play with productive failure. So the idea here is to give you some understanding of what's that core element, what's the core building block. The core building block is this idea of building around conceptual knowledge. So now that we have this understanding that productive failure is going to build conceptual knowledge, we have a huge design space that we can actually work with, and we have a lot of other questions that we can play with. I'm going to pause here and turn it back to Maria.
Okay, so as you're coming along our journey with us, so here's the next step. Why does it matter? So if it's really about doing well on an assessment, we can do well on assessment in many different ways. Is it really about that? Like, why are we trying to support the development of conceptual knowledge in our students? What does that afford us in terms of the future health professionals that we're supporting in our training? So I'm going to put up this quote. Eventually, they'll quit being novices without our having to do anything about it. The important question is, what will they become? Will they become experts in their lines of work, or will they swell the ranks of being competent or mediocre? And what this quote draws our attention to is the fact that not every education trajectory is the same, and not every educational experience is the same for the outcomes that we're looking for. We are looking for exceptional health professionals who are experts in their domains of work and are able to be dynamic and adaptive in handling the problems handling the challenges that patients need them to handle. So how do we ensure the right trajectory? If it's possible that we can get it wrong, how do we ensure that correct trajectory? And we've been talking about productive failure and ensuring that we're developing conceptual knowledge. But I'm going to start at the other end. And part of ensuring the right trajectory is understanding what an expert is. So what is it that we need our experts to be able to do in healthcare? We know that experts do what normally works. So they have a lot of knowledge and they apply that knowledge effectively. They've seen many, many problems before. They must be efficient and routinized. So we can't have people constantly reinventing the wheel every single time they encounter a particular challenge. There must be some efficiency of routinization. And so they must have procedural understanding and knowing what to do in many, many different situations that they might encounter. And that's important. But fast isn't going to be the only goal. Simple isn't going to be the only goal. And inevitably, there'll be problems they haven't seen before. So it doesn't matter what we do. As educators in any professional domain, we cannot possibly expose our students to every single variation of a situation they're going to find themselves in their work life. So there will be problems they haven't seen before. There will be novelty, there will be ambiguity, there will be complexity, and people will feel uncertain in their professional lives. And that has to also be understood as fundamental to expertise, rather than a challenge to expertise. If it's not, then the risk is that experts and professionals in any domain inappropriately try and fit unknown problems into known solutions because they're supposed to know. And so if you're supposed to know, I should know, and I'm going to try and make this work. But it can lead to many errors and definitely leads to mediocrity. Conceptual understanding is key to getting out of this. So it's knowing why you're doing what you're doing. And if you know why you're doing what you're doing, if that initial what solution isn't going to fit or isn't going to work in this situation, you're able to be more adaptive and flexible in figuring out how to serve that underlying why, even in the absence of the usual solution that you would have. So the deep conceptual understanding is actually core to being able to support flexibility, creativity, and innovation in moments of uncertainty, complexity, and ambiguity. I want to just emphasize that we talk about conceptual understanding and conceptual knowledge as being really crucial and important, and that's the sort of innovation side of adaptive expertise. But efficiency also matters too. The thing is that education already emphasizes efficiency. We're already getting a lot of procedural knowledge. We're already getting our students repeating things on tests and memorizing and telling us the steps and the checklists and the guidelines, and this is how everything works. But what we're not getting enough of is the conceptual understanding, and we're not getting enough of the whys into how we're preparing our future experts. So adaptive expertise really is a construct that encompasses both the what's and the whys. And reminds us that we have to be able through education to support the development of adaptive expertise by attending to both of these dimensions of how we need to know in order to be able to perform in healthcare settings. And that's why we've emphasized the conceptual knowledge piece. So here's a really technical definition of adaptive expertise. It's procedural fluency, so that's that procedural knowledge complemented by explicit conceptual understanding that permits new learning and invention in situations of novelty, ambiguity, and uncertainty. So what we have is a construct of expertise that is much more encompassing of the realities of the daily work that health professionals will find themselves doing. And core to this, and the person who helps us with our slides said this, so I thought I'd repeat it because I thought it was really quite interesting, is what you know helps you in moments that you don't know. And that's what it really comes down to. So in moments that you don't know, if you're armed with that deep understanding, you're armed with that conceptual knowledge, you're much better able to come up with a new solution in that moment of not knowing. So you're not stumped and you have a way forward. So conceptual knowledge is necessary for both the development and performance of being prepared for that future learning that we've talked about and emphasized. And that's really core to adaptive expertise. I want to pause for just a second and say, Catherine Lucy put this very nicely back in 2013 and said, what enduring social systems, biomedical and behavioral constructs must be mastered by students to help them understand the human condition, participate in continuous improvement of healthcare, and prepare for lifelong learning. And the reason I mention this is because when I say that the students need to have deep conceptual understanding, what domains that's in, how we define the basic science of the health professions is constantly evolving and changing. And we've done some work that's shown that if you include social science constructs, sociology constructs, behavioral constructs in how we understand why a patient is presenting at a certain point in time with a certain set of clinical signs and symptoms, that's extremely powerful, particularly as we work to serve everybody in our communities. So it's that broad conceptual knowledge that's necessary for adaptive expertise, not just the basic science, or actually, it's not just the basic science, it's redefining the basic sciences to include those things as being fundamental to the health professions. So productive failure supports the development of conceptual knowledge, and in doing so, supports the development of adaptive expertise, and that's why it matters. That is the important part here. It's not just about the classroom-based success. It's not just about success in clinical placements. It's about what kind of expertise and what future it's supporting for our health professionals. And Nikki, I'll turn it back to you. Nikki, you're still muted. Yeah.
Thank you. Hopefully at this point, you're convinced of a few things. So the first is you should be all proponents of productive failure. So at this point, everybody's all on board the productive failure train. We're all going to try to incorporate this and think about how we can utilize this in our own everyday practice. We also understand at this point that one of the reasons we want to do this, one of the reasons that we think this is going to be important, is because we recognize that productive failure is one way to get us to rich conceptual understanding and rich conceptual knowledge. And that rich conceptual knowledge will better prepare our students for future learning, which is a key capability of adaptive expertise. And so hopefully everyone is on board with that. I won't take a poll, I'll just trust that everyone is in agreement. So now we want to leave you with a way forward. So acknowledging that this is what we all want to do, how are we going to implement this? And this is sometimes the spot that is less well articulated in the literature, but we've done a little bit of work, and so we're going to share our work as well as the work of some colleagues that will help us better understand what are the key things you have to keep in mind if you want to implement productive failure into health professions education. So the first piece is about carefully selecting the problem-solving task. So as Maria showed you at the beginning, the way this works is you have the students being challenged to solve a problem with concepts that they haven't already learned, acknowledging that they don't know how to solve this problem. That's the whole point. It starts off from a position where you are confused, where you're unsure. You're starting off in a spot where you're supposed to be challenged. The key thing, though, is that you can't make the task or the problem so challenging that the learner gives up. So this is the tricky spot. We want them to feel challenged. We are acknowledging up front they're going to fail, but we have to choose the problem carefully so that they actually engage in the task and don't just give up before they ever get to the conceptual knowledge. So this early phase of really carefully choosing that problem is critical. The other thing to keep in mind is that you need to choose a problem-solving task that actually allows for multiple solutions, multiple strategies, multiple problem representations. This isn't a game where the students just have to guess the right answer. It's not a guess what I'm thinking game, right? What happens is you want the students to be able to really play with the problem, and there should be multiple angles in, because it's in the pursuit of those multiple angles that the students develop the rich conceptual knowledge. We want them trying something, not quite getting it, trying another path, not quite getting it. And so you really have to choose a problem that allows for that. And not every problem, in fact, allows for that kind of playing with the concept. The other thing is that we really want to be activating the learner's prior knowledge in solving the problem. So when we showed you that semantic network, that's really a representation of the knowledge that the student already has when they enter the problem-solving space, when they enter the instructional setting, whether it's a specific session or an assessment setting. They do have some knowledge coming in. They're not a blank slate. And ideally, you want to be activating that knowledge. I want to activate their existing semantic network so that they can build on it. I'm not trying to create a new mini one every single time. Right? The idea behind a semantic network is that it's supposed to be idiosyncratic, it's dynamic, it grows, it shifts. And our job as instructors is to create these tasks, create these learning opportunities that support that dynamic growth and changing and shifting in every student's semantic network. So we want to choose a problem that actually activates the learner's prior knowledge. The other thing we want to keep in mind, and this is one of the most important pieces, it's the one that we've studied the most in our lab. The other work that I just showed you is largely drawn on the work of Manu Kapoor. But what we've been really looking at is whether or not the student needs to personally experience the failure. And I'll tell you why we highlight this as a really important question. It's because no one likes to do this, right? As much as a colleague of ours always says, learning isn't fun. Learning fun things is fun. Learning boring things is boring. And learning hard things is hard. Productive failure is hard. So often students don't want to engage in it. And so we really need to understand, well, do they have to? What if I just tell you about the failures? What if I let you observe other students failing? Can I actually take some of that kind of personal struggle out of this and still get the benefits? And so we wanted to actually test this. And I won't go through the entire design because Maria said I had too many graphs, but I will quickly explain the general approach to the study. So we did a replication of that original study that looked at productive struggle versus direct instruction. And this time what we did is we have one group that experiences productive struggle exactly the same way. So they're trying to figure out the formula for creatinine clearance. We have another group which doesn't have to do the failure themselves. It's called the indirect failure group. And what we actually did in designing those materials is we took the failed examples from our previous experiment that the students and the participants generated, and we gave it as instructional materials to the students in the indirect failure study. And so basically they can see the errors of their colleagues, but they don't actually have to personally experience the failure. We then have both groups go through the exact same design. They go through the initial assessment phase, and they go ahead through the application and assessment and preparation for future learning assessments. And what we saw in that study is that failure is only productive when the students experience it personally. So the students in our indirect failure condition, they did not get the benefits on that preparation for future learning assessment. Yes, they all got the acquisition. Yes, they could do the application, but they did not show the same gains on the preparation for future learning. So what we learned from that is it's this active generation of the failure. That's what deepens the conceptual understanding. So it's really working with the student's own semantic network and not simply exposing them to somebody else's that matters. So with all of this, if we pull the thread through the entire last few minutes with us together, what we really want you to take from this and what we hope you're going to take from the entire time that you're at this conference is that curriculum design really should be guided by an understanding of the knowledge and capabilities of health professions as experts. Productive failure really supports the development of conceptual knowledge, preparation for future learning, and adaptive expertise. So that's really why we're advocating for this particular instructional methodology, acknowledging that there's many others, and we could also play with many of them in many ways. But the reason that we like this one and the reason we're advocating for it as a disruptive innovation is because we know it has all of these benefits. But we want to caution everyone that productive failure has to be deliberately designed and carefully calibrated. So failure for failure's sake, not good. And also we want to acknowledge this is difficult to do. So I think the next step as you work through the implementation is to think carefully and work collaboratively to think about how to really make this work for your learners and in your context well outside of our lab. So I think we've left some time for questions, and we're hoping we can all chat about how we would play with this and how we would push this further. But I'll just really quickly thank a few folks. So we run a lab called the Excel Lab at the Wilson Center at University of Toronto. And so that's all of our graduate students and postdocs. And we spend a lot of time just chatting about these things and pushing each other's thinking. And many of the students' work was reflected in the work that we described to you today. We've been funded from a number of different groups, and we've listed all of them here on the screen. And we're going to give a special shout out to Doug Buller, who creates our beautiful slides. So the one thing you cannot ask in the question session is how we made these slides, because we do not know how to, and so we can't tell you. But Doug makes the slides. He also has an amazing YouTube channel called Say Something, where he teaches you his approach to academic presentations, and you're welcome to take a look at that and learn from Doug there. We always like to have ongoing conversations, so we've included our email addresses and our link to our lab. And so we hope this is just the start of a conversation, and we welcome any sort of questions or comments that you have for us today or in the weeks and months moving forward. Thank you.
Thank you. That was incredible. Just so excited, about your presentation and to continue this conversation. So we are going to open it up for questions to our two presenters. So if you're interested in asking a question or making a comment, raise your hand and I will call on you. So our first is Rain Osborne.
Hey, thank you very much for the presentation. Really enjoyed it, and yeah, I think that was really gave me a lot of thoughts. One of the questions I had, just on your last point about having to experience the failure yourself, does that also apply in small groups? Like if you experience the failure as a small group of students, does that still personally experiencing it? Yeah, how does that work?
Yeah, we haven't tested that exact one, but we've done a little bit of that. I think if it's a small group activity, it would be fine. I think you just have to run, and we've done a little bit of this in our curriculum. It will work as a small group provided everyone is engaged in the activity. So we all know that the reality is in small groups, sometimes they're not really engaging in the activity. So somebody's doing it and everybody's watching. That's not the same thing. Everybody kind of dividing up the activity and you do your part and you do your part and then we come together. That's probably not going to work. But there's nothing about the fact that you're working in a group that necessarily means you can't experience the failure. You can. You just need to make sure that everyone's actively participating and actually contributing to the activity.
Great.
One thing, sorry,
Oh, go
can I
ahead.
add one
No, go
thing?
ahead, Maria. Yeah, sure.
It's also ensuring that the activity is a group activity. So I think that's a great way to avoid people carving it off and making it an individual activity. So there's been some work on that as well. Yeah.
Okay, Laura, you're up next.
Thank you. Great presentation. I have so many questions. In our curriculum, I'm from the MGH Institute of Health Professions. We do an integrated curriculum so that all of the sciences and clinical stuff is all, combined into these 4-week intensive courses. And having acknowledged before that, many of our faculty they're clinicians. They don't have a background in education. And, I think about sometimes one of the most challenging things I find in when students struggle and try and come up with their solutions to things is then the ability to make the connections. And I know you talked about that. And I just wondered if you could speak a little bit more to that, because I find that it's in our curriculum too, it's quick. They go from 4 weeks to 4 weeks to 4 weeks is how they build those connections and how we can really think about explicitly making sure that students are building those connections.
Yeah, I can add a few things to let Maria chime in. I think this is the part where it's really important to remember both halves of the productive struggle. So it's the struggle and it's the follow-up, right? So it is having that time for consolidation and feedback. And I think those are the moments where you have to make those connections explicit. That's the moment to just say, this is how these things are linked. Remember this thing we saw yesterday, and actually giving them the correct answer and giving them a chance to actually see how things fit together. I think one of the biggest mistakes we make as educators, and probably it is because we don't have training in education, is simply assuming and simply overestimating the ability of a novice student to see the connections, because we see them. So when you're an experienced faculty member, you're experienced basic science, you see how these things are connected. The novice doesn't. And so that's one of the biggest mistakes we make, is not taking the time to simply point it out. And sometimes it feels like, again, if I go back to this idea of active versus passive learning, people worry, well, shouldn't they just figure it out themselves? You've given them the chance to struggle. The benefit of the active learning wasn't just to struggle for the struggle's sake. They've done the part of it that was supposed to be active. They've experienced the struggle. Now it's your chance to just tell them and make the connections really, really clear.
Thank you.
And practically speaking, and Nikki usually says this, but she didn't this time, you can ask why. So some of the ways to get at some of the connections is a simple why question, and remembering to not stop at the what questions, which I think we all do. I mean, I do it with my kids. I'm like, what do you do next? I'm like, oh, wait a minute. I should be saying why. Because some of the times that will help make the connections much more explicit to faculty as well.
Yeah, that's a really good point. I think sometimes we also think that consolidation feedback part has to be something really in depth. It might not be. It might be just taking a moment to occasionally ask why questions, and that will tell you, did they make the connection or not? And then you can just go from there. It doesn't have to be a whole long drawn out thing. These are things you can do quickly at the bedside. You can do them quickly in the clinic. You can do them in the hallway. Like, it's not something that has to require a full on learning session.
Okay, great. Before I let Gail ask a question, I do have to give a shout out to Gail Jensen. Gail is part of the PTLI group, and she is she has a human Rolodex. She's a human Rolodex, and when we were thinking about this as a topic for this summit, immediately Gail was like, I know who we have to get, and she immediately said we need Maria and Nikki. And so we owe this incredible presentation in large part to Gail. So thank you, Gail.
I keep a folder with your papers, Nikki and Maria. So and they also have agreed that we're going to get a paper out of this too, to get into our literature. So that was a great presentation. It was really good. I have kind of a two-part question. One is, all the health, we're in the move of competency-based education, which one of the liabilities, it could become too procedural. That's one of the risks. And the second piece, so what do you recommend? And then the second piece is we're moving to assessment, which would be EPAs and trustable professional activities in the workplace. And it seems like there's a lot of predictive failure in the workplace it's guided because you want to keep your patients safe, because that learning is very robust, correct? So productive failure can occur in the clinic, is that right, under supervision? Yes?
Yeah, so we've done some work in particular with colleagues from Denmark who are looking at this and thinking about supervision in workplace settings that would support the development of adaptive expertise. And the productive failure one really comes up sometimes when there's an actual struggle in the problem solving that a student is experiencing, but also sometimes by creating struggle in a very routine situation, just by asking what if questions and making it hard. So, you can have a very routinized patient situation and say, okay, but what if I change this? And how would you then approach this? So basically taking simple moments when you might actually have more time and making them more complicated. So that's one of the thoughts that we've had, and some of the things that we've observed in clinic settings, which is, we're actually doing a talk at Amy about this, Nikki, in case you remember. And then in terms of the EPAs, I and CBME more broadly, I honestly think that it's a curricular modality that can be utilized in ways if we pay attention to the mechanisms that Nikki has outlined so nicely, and also the pedagogical approach of productive failure. I think we can do it in the structure of EPAs and competency-based education, but we have to redefine what we're assessing. We have to redefine what we're observing. We have to redefine what we care about. So if competency-based education is really about mastery and reproducing superior behavior in the sort of the deliberate practice model, we're not going to get to adaptive expertise just by doing that. But if we can try and make it about adaptive expertise, about those moments of uncertainty and how people perform in those moments when they encounter something new or when they encounter something ambiguous, then I think we still could leverage some of the affordances of CBE and EPAs and everything that comes with it to do that work. I'm not saying it's easy, but I think we can do it.
Okay, Julie, you're up next.
Thanks so much for the talk, Maria and Nicole. My name is Julie Tilson from the University of Southern California. My question is around learner reaction to this type of struggle. So I've had the fortune to get to try this a lot with my learners, and we tell them it's supposed to be hard. We make sure we have lots of processing time so that they feel successful at the end. And I think it is my own struggle to have them feel good about the process, right? Like there's an expectation that, you're going to teach me what I need to know, and I don't feel like I'm learning it right now. And I've seen some evidence around how to help students feel good about this and get the benefits of learning. But I'm just curious, like how much you all, especially when it's not one learning activity in a lab, but is, a semester-long course or a 3-year-long program, manage the student angst with what ultimately has better outcomes with, trying to make it feel good in the moment.
Yeah, and I think this is something we've talked about so many times, and I'm just seeing some of the comments in the chat. I think sometimes residency and fellowship programs in themselves are built around very many ways that failure that doesn't feel good. Like often residents feel like they're just wandering around the ward. They really want more support. This doesn't feel good. I feel like I don't know what I'm doing. And that's the worst feeling in the world. So whether it's on the ward or in the clinic or in the classroom, no one likes to feel like they have no idea what they're doing here. And so I think the key piece with all of this is that consolidation. So almost any of us can exist with a momentary feeling of, I'm not quite sure what to do. And that's what's supposed to happen with productive failure. But there is supposed to be an aha later on. There's supposed to be an aha where now I get it. And it's okay if the aha doesn't come in 2 minutes, maybe it comes in a little bit, but we need to balance out those moments of kind of aha, I'm getting it. I feel like this is moving forward. And all of us have experienced that. I mean, we do this in our own teaching. We do this in our own graduate teaching, our students will tell us all the time, oh, now I get it. Okay, fine, now I get it. And it's those kinds of moments that we have to make sure there's room for. And we have to also have to asking questions that's letting the students tell us when they're not getting it. So it's the making sure that we're checking in and confirming that they are actually learning things in the end, and it's not just them running around and experiencing the failure and never experiencing those moments. It's our assumption sometimes that as long as you've gone through it, you must have learned it and everything's fine. We have to stop that and pick moments where we're going to actively investigate and make sure and check in that people are feeling like their knowledge base is moving forward. I think the other piece of that is the calibration of the task, though. Not everything, if you make it too difficult, it's going to be just demoralizing and defeating, and nobody wants that.
The only things I would add is that some of the work at U of T's medical school, we've also had some learners who've experienced the curriculum come back and talk to their colleagues in the first and second years. And that's been very helpful because they will say, oh, we didn't really like it, but then we eventually we understand now. We see what they were trying to do and we did well and it's okay. The second thing is we are a pass-fail school, which actually does help. So that's sort of a big picture piece, but it does alleviate some of the stress of the specific little assessments that they're more formative now across the curriculum. And the third thing is having faculty also model some of that uncertainty and not knowing and struggling. So.
Okay, Michael, you're up next.
If the purpose of the productive failure is to produce the cognitive dissonance that's a prerequisite for this new applied learning, is it not then really important to help examine why did it fail? Understanding why that strategy didn't lead to the successful outcome? And is your answer to how you get them to do that is to ask why do they think it failed?
So it can be both. So you can ask why, it can be asking why it failed, but it can also be asking why the right answer is the right one. And that can kind of illuminate, or one of the many right answers, what makes them right. So sometimes you don't want to spend too much time delving into what you did wrong, but you can show them, and this is where the conceptual knowledge piece comes in. It's when understanding why the right answer is the right answer, that's what helps you build the conceptual knowledge. So when you get to that time for telling, it makes it easier. And this is one of the things that people miss if you don't do the productive struggle. If I just give you the right answer off the bat, often people miss the why. They gloss right over it because it seems obvious. We've all experienced it. When an expert just tells you something and you haven't experienced it yourself, you're like, oh yeah, I get it. Until you try to do it yourself and you realize, actually, I don't understand this at all. I don't understand whatsoever. And so it's in that struggle and getting it wrong, when then they show you what was right, you're like, oh, that's what I was doing incorrectly. And so that's kind of the dissonance that you're trying to provoke.
Okay, Mary.
All right. Well, also, thank you very much for the presentation. As you were speaking, and I was thinking about what I would do to put in place to prepare students to engage in a different form of learning, right? Where discomfort is capitalized upon. I thought about when I worked in a problem-based curriculum, as part of their orientation, I created a funeral for lecture-based learning. And we symbolically went through this, like all of the things, oh, I'll miss falling asleep with a 3-hour lecture or whatnot. Similarly, I started a hybrid program, and we really were very thoughtful about creating an orientation to normalize a new, to establish a new normal. And I know Julie started asking you about that, but have you thought of a way to create a mental model and orientation in programs or something, whether it's selected readings, et cetera, to help students understand the why with this particular technique?
I mean, the short answer is yes. Does it work? I don't know. that part is so. I mean, what we've tried to do is right from the beginning of orientation in our medical school curriculum. I do a lecture, for example, and I talk them through this and why this matters and why our curriculum is built this way and why it's sequenced in these way and so we have them look at the weekly schedule and say, okay, so where do you see that we've now purposely put you in a cycle of productive struggle? We kind of call it struggle instead of failure sometimes. So how are you seeing how the design is informed by this pedagogy, and we do actually have them try and actively generate ideas about where they're seeing it in their own curriculum, so to try and get them really engaged in it. I think it might help. I don't know if it helps everybody. I think, if COVID hasn't helped because that lecture was poorly attended, to be honest with you. When it was in person and mandatory, it was a little bit easier. So there's that. But I do think that we're trying to help them know, and we're providing online resources for them to know. We're ensuring that our faculty are well versed and able to explain why they're doing what they're doing. And again, that somebody was saying in the chat that you have to think about culture. That's true. So not every faculty member is on board. So that's a problem. So all of those pieces, I think it takes time, but we're still committed to it. So I think we're going to continue to do it. We believe it works. We believe it helps our students in the long run, and our students in the long run seem to think it helps. So that's actually very reassuring.
Yeah, I think what those things might do, and again, when we say, does it work? Like, again, the orienting task is what matters. So as long as they engage in the activity, this will all work just fine. But in terms of providing them these other supports, that might be what they need to not give up. And if that's the goal, like that, again, I think understanding the mechanism, the goal of providing these other things isn't so much to alleviate all the distress and discomfort, because you can't, but it might just help them keep going and not give up on the task. And that might be just the best you can do. I'm not sure there's a way to set this up so that everybody's running around loving it. I don't think that's possible, but they certainly shouldn't walk around feeling like it's a failure all the time. Like we don't want that. We want people to walk away feeling like they are learning, and it's just making sure that they continue to engage and not just shut down.
Thank you.
All right, Alan.
Hi, thank you for your presentation. You kind of mentioned a bit about culture of the faculty, but could you talk a little bit about assessment of the learner, maybe their culture, their age, maybe regional differences or international differences? What should we as faculty be aware of? Thank you, and thank you for the smiles.
So I think there's a lot of pieces here. Like, I think it depends on where. It matters where your learners are coming from. Like we're at the University of Toronto. This is a highly competitive medical school. The students who are coming from our program are coming from highly competitive programs, and often in the natural and biomedical sciences, where they're used to getting the right answer. They're not used to multiple pathways in. They want to know, this was what I was supposed to do. And they will say, why don't you just tell me what the right answer is? Like, that's the background that they're coming from. As opposed to if you were bringing students who are coming from humanities backgrounds, social science backgrounds, where they might be used to there no being a single right answer, and maybe a little bit more flexible on not always getting a perfect score. Like, I do think that there are some kind of prerequisites that you have to keep in mind. But I also think it's more important to think about that in terms of, again, calibrating the task, thinking about their prior knowledge. There's not a lot you can do about, like, everyone can change their medical school admission or their PT school admission and get in only art students. That might be something to consider. But at the end of the day, I think it's just providing the right support so that people don't back down. I don't know, Maria, if you want to add anything.
No, only that our rehab sciences, our PTOT schools and SLP is also extremely hard to get into, arguably harder. So it's the same group of students.
Okay, Mark.
Hi, everybody. Thanks. That talk was awesome. Appreciate the opportunity to be here. And I have a question that's a little bit related to Julia's comment over here in the chat. I'm thinking about faculty. I think about myself a lot. It's my favorite topic. And thinking about the whole failure part. So two things with the culture. So if faculty don't see themselves as an expert who doesn't struggle or shouldn't struggle, how can we navigate that part? And the second thing, I like Julie's question here about should we emphasize more in faculty, junior faculty training or new faculty training, the failure struggle part? And would that help as they move to teaching students? Do you think?
I mean, I haven't. So yes, I think so. It's maybe my short answer. So the adaptive expertise piece of this is it could be a talk in and of itself, as could the integration piece, Nikki, and all the levels of processing memory. So, but the constructs of expertise that are still quite dominant, particularly in spaces like health professions, are still very much rooted in knowing and certainty and not struggling and not failing. And I think COVID shook that. I do. And I think it shook it hopefully productively as we move forward, because I do think faculty need to start seeing themselves as adaptive experts, which means making room for not knowing and making room for struggling and making room for that as part of your expertise, so that it doesn't challenge your feelings of self-efficacy, and it doesn't bring about that feeling of lack of resilience and burnout that often is accompanied by those the idea that I don't know what to do, I'm not good at this, I don't want to be here, those moments. So I think there's some room in faculty development to think about constructions of expertise and how they link to all of those elements of what it means to be an expert in a particular domain. And I wonder if you're right, maybe a nice faculty development exercise that's grounded in, bringing some of your failures, and let's talk through them and think about how they're actually learning opportunities or what you were able to do in response to that, might not be a bad idea. But focusing on the knowledge rather than the affect, because we come from the cognitive sciences, so I would focus it on as a learning opportunity rather than managing people's affective responses to those moments, which is a different thing and can have its own space.
Yeah, I think that's also kind of related to Jennifer's comment in the chat. I do think there's a piece here about kind of the dose of the failure. The struggle doesn't have to always be a really big, huge, oh my goodness, I didn't accomplish this. Like if you just think even to the experiment we did, they were asked to try to figure out a formula. They didn't figure out the formula. Nobody was walking away crying, like it was fine. They just didn't figure out the formula. We kept it moving. The point is that it's just doing a task. We call it failure because you didn't succeed at the task. That's all. It doesn't always have to be, we're not talking about people failing courses. We're not talking about something that has to be really, really difficult and traumatic. And as experts, we all have experienced that. We all know at the end, even though it doesn't feel good, we know full well we make mistakes sometimes. We don't know the right answer sometimes, and we do that. So it doesn't have to be really, really huge failure. I really want to push that. Sometimes it might just be a small activity that someone did and they didn't quite get the answer, or just asking them a question that they didn't know the answer to. That's fine. It doesn't always have to be something that would require management of the affect, to be honest.
Great, thank you. Lee.
Hi, my name's Lee. I own a clinic in Northern California, and I've had 82 interns in my career. I know that because I've had to number them because I'm getting older and can't remember when they were here anymore. But the intern who I have right now, who we're going to go see a patient in 20 minutes with, he's one of the first ones who came to me and said, I'm really a kinesthetic learner. I really need to try it on patients and see it in the moment there. And that's one of the first students I've ever had like that. And I said, okay, when we were talking about his learning strategy and everything, I said, okay, then I'm gonna give you feedback in the moment. It might sound harsh, I might sound like a jerk, I don't know, but that's just what we have to do for you to learn, to keep the patient safe and to make the treatment productive. And he's been great with it. I mean, just this morning we had a patient who we're seeing pro bono just because he went over his benefits, and he still has a little bit more to do, and he was doing a treatment technique on him, and I said, no, you need to move this tool this way so that you get the optimal effect here. And I mean, the wrong student, that could have been like, oh gosh, he's challenging me and he's making me feel bad, blah blah blah. This guy just takes it head on and just rolls with it, and it's great. So I think really the big thing is knowing, and I have that conversation with all my students when they start, what kind of a learner are you? Because that's important so that I can give you the proper feedback at the right time to understand this. So I think we have to be honest, we have to create that space for them to learn, but then we have to know how they learn best.
Yeah, I think that some of the work we've done, and our colleague Ryan Bridges is really intrigued by this space. I think I would call that co-regulation of learning, and I think that having a sort of shared idea of what exactly is going to happen here, and it isn't going to. So it's not about the learner preferences only. It's also about both of you being on the same page in terms of what this learning experience is going to be about. And not everyone is going to be the same, but I think that it's a good point, and you can't really leverage the learning experiences in clinical settings unless people are all sort of understanding what they're there to do together from a learning perspective. Yeah.
All right, Anne.
Hi, thank you. Andy Mejia Downs from the College of St. Mary. So I've used this concept of productive failure successfully in teaching EKG interpretation, for example. But can you speak to the evidence and the application of using this concept for something less objective, like cultural competence or teaching about therapist-patient interactions?
Nikki, I can start. I think that, so I wouldn't point to a specific study. I would point to the broader work that we've done around thinking about the different domains that matter for expertise in health professions. And some of the work in particular that reminds me of what you're describing is in psychiatry, where you have a struggle, and you're struggling because it's truly an uncertain space. Like the ambiguity is a real feature of this particular clinical problem-solving space. And so you're not really giving people certainty. What you're giving them is the best explanation that the knowledge can provide them at that time, and pointing perhaps to some of the limitations of that. So I don't think there's a problem with that. And the reason I say that is because that's also a reality of healthcare. That we can only do our best with what we have at a given moment in time, and that those explanations and those underlying whys might actually change. The other thing that's come up in psychiatry is that those psychiatrists will say, well, that there are different competing models of why in terms of understanding some of the ways that patients present. So maybe sometimes it is presenting some of that uncertainty as the answer, because that is the answer. So I think not shying away from spaces where ambiguity is inherent is probably really important, particularly as we think about expertise in that way that makes that part of your expert practice. It's okay. I don't have to be certain here. This is not that space. So I think that feedback and consolidation can happen even without certainty.
Yeah, and I think it also adds to what Maria was talking about in the presentation too. And I think what we've seen is that this idea of conceptual knowledge, yes, it lends itself well when you're talking about EKG diagnosis or developing a formula, but we would argue it applies equally well in the spaces that you just described. So there is a conceptual knowledge base to understanding collaboration. That might be social justice. Maybe the conceptual knowledge space is an understanding of power. Like, I think it still applies. So even if you were looking at some of these other concepts, I still think you would be able to play with it. It's just being flexible with what is your goal. What's the conceptual knowledge and what is the procedural knowledge? And this is why we're saying understanding the mechanism makes it easier to design the tool, because you're no longer stuck with kind of the peripheral instantiation, and you could think about what am I really trying to get at.
Right, thanks.
Thank you so much. Unfortunately, this is going to stay on task and to stay on track and to be respectful of everyone's time, this is going to have to be our last question. So what a way to end with Susie.
Thank you. And thank you both for an exceptional presentation. I'm Susie Singer at Washington University in St. Louis. I'm interested in unplanned failure as well as the ideas of productive failure, which are essentially planned, and wondering whether you're rolling in the unplanned failure that occur in the clinical practice or in the teaching or in our lives into that as a way to extend the deep learning and development of adaptive expertise.
I think that's a great question. I think I would see it as an opportunity, absolutely. To take that unplanned failure and use some of the techniques that you would use in a planned failure situation to navigate it and to make it a meaningful and productive learning experience. Otherwise, I think it runs the risk of not being a very productive learning experience, which is the real issue there. I don't know that I mean, in the clinic, yes, absolutely. Unplanned failure could happen all the time. And I think people are navigating and working through that. But in classroom basis, I don't think we've looked at that as much. I still think you could do it. I think you run the risk. Some of that calibration might be missing. Some of the psychological safety that it requires, that setup might be missing. Some of the co-regulation, we're all here to do the same thing, might be missing. So it would raise some challenges, definitely. But again, it's better than leaving it unproductive. So
I think the way to link it to literature.
Learning activity that we developed.
No, go ahead, Susie.
I was just going to say the learning activity that we had been using, at least at Washington University, is an assessment of what really did happen. It has to be you have to have faculty be willing to disclose their own experiences in clinical practice and assess what it is that occurred, what the conditions were, what did you feel like, what did the patient do or not do, and all of the whole literature about disclosure and analysis of unplanned errors, I think could really add to the work before they're in the clinic, so that they do have psychological safety, but they also know that we are vulnerable in error regularly in our work.
yeah, we have a chair of learner wellness, Heather. You know Heather, Nikki. She's doing something like this where she's developing. She wants to do a podcast series, interviewing clinicians around these exact moments and sort of normalizing all of this in clinical practice. So yeah, that's a great idea.
mean, I was thinking one of the greatest things you could do is flip on its head what people think they're supposed to do after an unplanned failure. So, you know, yes, you want to make sure that it doesn't happen again. You also want to manage. You want to manage the emotion of it. You want to manage the clinical knowledge aspect. But I think it's keep in mind that's also a time for telling. Like just thinking of an unplanned failure as a time for telling, and then restructuring what you're going to tell would be really key. But it's an interesting way to think about it for sure.
Okay. Well, I'm really sad that our time has come to a close here, but thank you so much, Maria and Nikki, for an incredible presentation and for sharing your thoughts and expertise with us. You know, we are really excited to have had you here. So thank you. And I am going to reshare my screen here. And we're going to talk a little bit before we sign off here just about what's to come. Again, thank you so much, Nikki and Maria. You know, they're going to provide a handout on this presentation, and that'll be posted on the PTLI website sometime in the next few days. And I'll be sending additional information in a post-event email, you know, with ways to access recordings of the sessions and lots of materials after the event. Including in that is we did put out a call for platform submissions. We were excited to receive 5 different platforms. In the email that I sent you earlier this week and then resent earlier today, there is a link to view those platform presentations. They are from our colleagues that are implementing, you know, innovative ideas around the 3 conference topics, you know, at their institutions. And so I hope that you will take advantage of the opportunity to review those platform presentations either before tomorrow's sessions or afterwards to continue to further the conversation. And so what are we in for tomorrow? So we have a super exciting day planned for you tomorrow. We'll start promptly at 11 Eastern. We have 3 different topic sessions. Each one is structured similarly. The first one is around the application of the learning sciences to PT education. The second one is around faculty preparation and development. And the final one is around assessment practices. Each of those will start with some presentations to get us started. And then if you've attended our sessions in our conference in the past, we're going to try something a little new. We really want to make sure that we hear from all the voices and engage as many voices as possible. So we're going to do one of those uncomfortable things, is we're going to put everybody in breakout rooms and we're going to give you some guided questions, ask you to use a Jamboard. We're going to stretch our technological capabilities and comfort tomorrow. And then each small group will bring everybody back together, for a large group discussion. After each of the end of the 3 topic sessions, we will have a final sort of reflection and large group sort of broad discussion about all the themes, that we have explored throughout the 2 days, and really hope to move towards, some individual and maybe collective action items. And so we hope that, we get there this weekend. Just a few reminders and ground rules. Just when you're in the waiting room, if you'll use your screen name, have it reflect your actual name. We are going to try and make sure that before we enter you that, we recognize your name and make sure that those who are registered, and try to avoid any uncomfortable situations with people who don't belong in this session. I've had that happen, unfortunately, where suddenly there was random body parts, on the screen. So we're going to try to avoid those things. Try to remember to mute unless you're speaking. We are going to record all of the presentations tomorrow. We will not be recording the discussion. And so those presentations will be, again, posted to the PTLI website. We purposely are not recording the discussion because we want to make sure that people feel comfortable, and because we're going to post it, really sharing, their true thoughts and ideas. I'll just mention that. Again, we're going to use the same procedure, during the big group discussions tomorrow, to raise your hand to get in the queue to speak. Again, everybody's been respectful, today and in the past, but just we ask that speakers limit their responses to 2 minutes, just to make sure that all those that want to speak have that opportunity. And we are going to, like we did today, turn off the chat during the speaker presentation so that everyone gives those speakers who have prepared presentations our full attention. And we also ask that what we really want is everyone to actively participate in the conversation in the live conversation as much as possible. The chat can sometimes take on a life of its own, and sometimes it's hard to engage in the chat and in the live conversation. And so, we encourage everyone to engage in the live conversation as much as possible. And like I said, at the end of the day, we will, have a summary session where we'll try to do some take homes, and really hopefully moving to some action items, again, whether that's individually for you to go back to your institution, implement some strategies, or if there's some collective action, that we can identify from the group. All right. And we also, before we want to sign off, want to thank Rehab Essentials. They have generously sponsored this year's event, and so we are very thankful to Rehab Essentials for their support. I think that's it. We'll see you tomorrow.